Let me start the recording. Or if anyone else was here in the room, I don't know how many participants were there, but I guess Maria wasn't there. Let's wait for like a few 1 or 2 minutes to let her join. But then, because there is a very important mechanism of how this drug interacts with halothane and digoxin, so this mechanism is very important to understand. So you people should like join quickly. So I think I should begin. Okay, she's here also. So let's continue. Let's just continue. So okay. So I was talking about the hyperkalemia. Okay, so you know the cells are the we call the cells are the bags of potassium. So there is a lot of potassium stored inside. So when there will be not this activity for a longer period of time, there is thus this homeostatic mechanism going inside your body, which is like counteractive to what you are doing from the drug. Because when you're giving this drug, it's like blocking all the depolarizing mechanisms, and there will be no sodium going in, no potassium coming out, no calcium coming out from your sarcoplasmic reticulum. But after some time, when your brain knows that there is some problem going on inside, what happens? Excessive calcium will be released from these cells, which are the bags of potassium. So excessive potassium will be released, and because of excessive potassium release in the blood, you will see hyperkalemia. So this is the reason why you see hyperkalemia. So it's not like just you give the drug and you will see hyperkalemia. No, potassium levels will be normal, but in prolonged cases, okay, when the drug is like binded to the receptor for a very long period of time, so then you will see hyperkalemia because of the defensive mechanism of your body itself. Okay, so keep this thing clear. Now we have this clinical the contraindications, and you are not gonna give this drug with these things. Okay, there are 3 drug names written, very important. I have made it bold because you should know how they hinder these drugs mechanism of action. So first let's talk about the drugs, then I will talk about how it's causing problem in congestive cardiac failure. Okay, so first of all, digoxin. So digoxin, or we call it digitalis. There are 2 names for the same drug, digoxin and digitalis. Okay, both are generic names. So digoxin is a cardiac glycoside. It falls in that category. You will be studying it in detail in the cardio pharmacology, but now I will tell you how it's causing problems. Cardiac physium में पढ़ेंगे. And this is a cardiac glycoside, glycoside. Okay, this is the class of this drug. So there are some doctors in the hospital who do ask in which class digoxin lies. Remember, cardiac glycoside. Okay, so this is I'm just clearing this drawing because I have to make these receptors here. Okay, receptors, transporters. Now this is a membrane. Okay, and here is one transporter, and here is this other transporter. Okay, so this transporter is called sodium calcium exchanger. Okay, so we have it like this. Okay, we call it sodium. Calcium. I'm just writing sodium and calcium. Okay, I'm not writing exchanger. You can draw it also. So sodium calcium exchanger. So what happens here is calcium comes out. Okay, calcium comes out and sodium comes in. So calcium goes out and sodium comes in. So where this calcium is going, why this calcium is going out from the sarcoplasmic reticulum? Definitely, we are talking about the skeletal muscles. Okay, so the sarcoplasmic reticulum, calcium is stored. That will go out. When the calcium will go out, sodium will come in, because this is a sodium calcium exchanger. Okay, so when the sodium will come in, there will be more and more positive charges. Okay, and there is already, this cell already has lots of potassium inside. So the next transporter will be sodium potassium adipase pump. This is an exchanger, but this is an adipase pump. Okay, there is a difference between an exchanger and an adipase pump. So the AD-based pump needs ATP. It needs energy, okay, to perform. It just can't do its action if ATP is not sufficient. Okay, so this is the pump which needs depolarization, okay, which needs the impulses. Okay, so when the sodium is more inside, that sodium will go out from here. The sodium will go out, and in return, the potassium from outside will come inside. Okay, so now what your digoxin is doing, the most important, where it is functioning in this whole mechanism. Is it functioning on the sarcoplasmic reticulum? No. Is it functioning on sodium calcium exchanger? No. It is functioning here on this transporter, the sodium potassium ATPase pump. Your digoxin is inhibiting this pump. Now, there is a patient, a cardiac patient with, let's say, arrhythmia. We have given digoxin to that patient because the clinical use of digoxin is like atrial fibrillation, okay, arrhythmias, etc. So let's say there is this conduction problem in this patient, and that patient is of AFib, okay, and he is taking this digoxin, and what is digoxin is doing in that? It is inhibiting this sodium potassium exchanger. Now, when this sodium potassium AD pump is inhibited, no potassium is coming in, no sodium is going out. So there will be more and more sodium inside and less potassium inside. You're getting my point? The potassium is more in your blood now and less in your cells. The sodium is, your cells become the bags of sodium. There is more and more sodium accumulation inside your cell. Okay, this will ultimately give signals to your calcium, to your this sodium calcium exchanger. This will give ultimately signals to this that please, we do not want more sodium. There is already much saturation inside. So this will also shut down. This will also not work. So this sodium will not come from outside to inside because the calcium is not going outside. This is the primary ion that was working for this exchanger. Okay, so now what your digoxin did, more sodium is inside, okay, because this exchanger is stopped. The sodium that was already inside because of this exchanger is present inside. It cannot go outside. And because of more saturation of sodium, this exchanger stopped working and more calcium remains inside your sarcoplasmic reticulum. So now your cells are ultimately, what will be the final result? The final result will be more and more calcium inside because of digoxin. Okay, now what calcium will do? What is the function of calcium inside your cell? It is a positive ionotropic agent. Okay, positive ionotropic means, I told you what is the meaning of ionotropic. Okay, positive means more activity, and ionotropic means more heart rate. Okay, sorry, where is my, this is my rubber, this is my pen. Okay, so we have this more myocardial contractility, that is ionotropic. Okay, and heart rate is chronotropic. So calcium will cause positive ionotropicity. Okay, that is more and more contraction of your myocardium will happen. But there is now your mind should have a very good question. The patient was taking digoxin for atrial fibrillation. The heart was already contracting more. Are we giving the patient a drug that will increase that action? No. No. This is not the final step for digoxin yet. Okay. Now, because of this excessive myocardial contractility, or I may increase my screen diameter, and I should make this a step down here. Because of this excessive myocardial contractility, what will be the next step? There is this nerve which we call vagus, which is a parasympathetic nerve. Okay, and it innervates your myocardium. Because of this excessive sympathetic activity, your parasympathetic will be activated naturally. This is your counterbalance mechanism of your body, which is you are being gifted by that from God, okay, from your Allah. So because of the sympathetic, the parasympathetic will activate to overcome it. So now your vagus is activated, and that vagus will decrease your heart rate, and you are treating a patient of AFib now. This is your mechanism of action for digoxin. We will definitely repeat this again, mechanism in your cardiac physiology, when we will be studying there. But right now, it was important for you to understand how digoxin is, why you are giving why you can't give these drugs to a patient with digoxin. Now, this is causing already hyperkalemia. What do you want? No, no more. There is already more and more calcium, potassium outside in your blood, and you're not pushing it inside. And if you will give this drug to this patient who is already taking digoxin, this will be like super exceeded. Okay, and that will cause another problem. So this is like very interesting mechanism that I just taught you. So please remember this, and it will help you in cardiac physiology also. Okay. Then we have this diuretic, another very beautiful class of drugs, which is given to the patients to decrease their blood volume and correct their electrolyte imbalance. Okay, so we don't give diuretics only to patients who have like renal problems. We give diuretics to patients who are having congestive cardiac failure, or who are having the what can I say, who are having edema. Okay, we can give to that also. Who are having increased intracranial pressure, we give to them also. Okay, so who are going in volume overload because of heart failure, we give to them also. So there are so many uses of diuretics. But then there is this class of diuretics which we call potassium sparing diuretics, and you might have heard the name spironolactone. Okay, that diuretic spares potassium and does not allow potassium to move and go outside your body. Okay, it saves potassium inside your blood. And when you give this neuromuscular junction blockers along with this diuretic, the same problem, hyperkalemia. And we do not want hyperkalemia, okay? The ions should always remain in their normal range. When they are low or when they are high, when this electrolyte imbalance occurs, there are many problems going on. So we have to keep all these ions in their normal values. So never give diuretic and digoxin with them. Why? You know it will exceed, super exceed hyperkalemia. And then there is another drug which is halothane. Please give me 1 second. I have to switch on my light. Okay, people. Sorry, I was kind of blind. Now halothane. So the third drug is halothane. Okay, when we talk about halothane, this is a very important mechanism of action, and it's different from these two drugs. Okay, halothane is a anesthetic drug. Okay, so you will study this in your CNS pharmacology. Okay, so what this drug is doing, what halothane is doing, its mechanism of action is different. Okay, there is this electron transport chain which you will study in your biochemistry next. Like we finished vitamins, so next will be uh, your metabolism. In that you will study electron transport chain. Okay, so this halothane inhibits this. No electron transport chain. Now when your electron transport chain is not there, no ATP, no NADPH, oh, no NADPH, okay, no ATP, no NADPH, no energy. When there will be no ATP, you know NADPH also gives ATPs, like 3 ATPs. Okay, 1 NADP gives 3 ATPs. Remember this. Okay, so no ATP, no NADP, shutdown of electron transport chain. We don't have energy. We can't, this transporter, this sodium, potassium, ATPase pump needs ATPs. Okay, this sodium potassium ATPase pump will not work. Again, no sodium coming in and no potassium going out. You have this hyperkalemia thing one more time, and ultimately because of this, the calcium inside your skeletal muscle in your sarcoplasmic reticulum will be more. Okay, so same mechanism that was with digoxin. So digoxin was inhibiting this pump, and halothane is not acting on this pump, but halothane is inhibiting ETC, electron transport chain. And because we do not have ATP, this pump will ultimately stop. So the end result is again this pump. So you have to just make this picture or something, okay, with these notes, or you can like photocopy these notes or make this picture with these notes, that ultimately the end result for all the side effects is this pump, the problem with this pump. But you should know the basic mechanism. Halothane has an action on ETC first, And then the second step is no ATP, and the third step is this pump is not working, and the fourth step is increased calcium. Okay, so we are going in steps to reach that level. But in digoxin and diuretic, in digoxin we were inhibiting this pump directly. Okay, number one. So the first step is this. And in diuretic, we were working on the renal tubules. Okay, we were not working on this level. We were only working on tubules. And this drug was also, but this drug was working on this level. Okay, and potassium was also sparing at that level. So it will ultimately potassium and potassium adds because of this also and because of this also, so causing problems. So please remember, so when your calcium levels, when you give halothane and these drugs together, your calcium level ultimately is more, okay, in your sarcoplasmic reticulum. Then your calcium will cause this hypercontractility of skeletal muscles. Okay, your skeletal muscle will like contract more and more, and then you will see hypertonia. Hypertonia. And what was hypertonia? I told you. Hypertonia is excessive contraction of your skeletal muscles, which is seen in malignant hypertension. So we have this also now. Getting my point? So people, please, this NMJ blocker mechanisms are very important, okay, to understand all of this. I'm glad you take this live lecture, and now you like understand why are these side effects and why these drugs are so important. With you whenever you are giving you are performing a surgery and you think of making the patient's skeletal muscles paralyzed by these two agents, please see the drug chart of that patient. The patient should not be using any of these, okay, and the patient should not be CCF, like congestive cardiac failure patient. Okay, the patient should not be having burn, because in burn cases you have hyperkalemia, because in burn cases you're like your electrolyte is already imbalanced. Okay, the patient should not be having any crushing injury too. Okay, so please make sure your patients should not have these things before giving these drugs. Now another very important point, I am clearing this all. Now another important point is, this is the last point of this topic. Now your patient is having this malignant hypertension, okay, because of halothane, and your calcium is just releasing more and more from your sarcoplasmic reticulum. You need to stop this. There is a drug that stops this, that does not allow calcium to release from the sarcoplasmic reticulum, or in other words, I can say it blocks the release of calcium from sarcoplasmic reticulum, and that drug is dantrolene, Dantrolene, okay? That drug is called dantrolene. So you can write it, that dantrolene, what dantrolene do, it blocks calcium release from sarcoplasmic reticulum. Okay, so it will treat the hypertonicity because of the use of halothane and these drugs together. So if by mistake you give the patient these drugs together, the patient is taking halothane and you give him this also, okay, dantrolene is your treatment then. Okay, to end this side effect, give dantrolene. So this is your topic for today, which was on neuromuscular junction. Now our next topic and our last topic that is for today, which is left, is the synthesis of acetylcholine. We still have time, so let's study the synthesis of acetylcholine. Tomorrow we will be studying the acetylcholine. Sorry, not the acetylcholine. Tomorrow we will be studying the sympathomimetics. So we have to study the synthesis of norepinephrine, not acetylcholine. I'm teaching you acetylcholine since so many days, so it's like on my tongue now. So now norepinephrine. So we are done with the cholinergic, agonist, and antagonist completely. No drug is remaining. Okay. We also studied OP poisoning. Okay. So nothing is remaining. Now let's move to adrenergic section. So now this is your picture from your Lippincott pharmacology. Okay. Now how your norepinephrine is synthesized. So the next topic, the new chapter. Okay. Now you see this little thing. This picture is a bit blurred, but if you have Lippincott, you can also open your own book. So yeah, you see this little buddy which is called tyrosine. This tyrosine is an amino acid. Okay, this is an amino acid. So when you eat proteins, proteins are made up of amino acids. So you're getting this tyrosine from your food, or you can say from your GI tract. It is absorbed into the blood from your GI tract, from your intestines, okay? Because you're taking this in the form of food. Now, when it is absorbed from the blood, okay, into your, and it's into your extracellular space, and from your extracellular space, there is this transporter which is called sodium tyrosine co-transporter, okay? Sodium tyrosine co. Like when we say co-transporter, it means both of the things will move in one direction. Like sodium and tyrosine both will come inside together. That is why we are saying it co-transporter. Okay, or I can say it is tyrosine reuptake pump. I've written over here. So now the tyrosine and sodium comes inside. Okay, now when they come inside, what happens? This tyrosine is converted to DOPA. Okay, DOPA. This is the first step of conversion. Okay, so this DOPA is converted to dopamine. There are definitely enzymes at this levels. Okay, but they have not written the enzymes. You just have to understand how epinephrine is being formed and is released. Okay, so tyrosine is converted to DOPA. DOPA is converted to dopamine, and then dopamine is converted, is got into this synaptic vesicle, and there in that synaptic vesicle, this dopamine is converted to norepinephrine. So now this blue color triangles are norepinephrine. Okay, not epi, but norepi. Okay, norepinephrine. And this norepinephrine is further on can be converted to epi. Okay, and this norepinephrine is when this synaptic vesicle comes and binds to this membrane, it touches it. Okay, it's like burst up, and when it's burst up, this norepinephrine is released into this synaptic space. Okay, and now you see this norepinephrine is all out. It will go to the membrane of another neuron, because this norepinephrine and epinephrine mechanisms is sympathetic. Okay, sympathetic mechanism. So in sympathetic we have two neurons always. So the norepinephrine is released from this neuron, because in the preganglionic we always have ACH. Remember this, I told you. Okay, so norepinephrine is released from the second neuron. Okay, and then it will go to this effector organ. We have this receptor. This receptor can be alpha 1, can be not alpha 2. This receptor can be alpha 1. This receptor can be beta 1. This receptor can be beta 2. Okay, not alpha 2, because this receptor is alpha 2. Okay, so this receptor can be alpha 1, beta 2. Norepinephrine will act on these receptors, and wherever these receptors are present, we will see the effects. Okay, so you have understood this little thing which I'm gonna tell you here, and then this alpha 2 is present at this presynaptic neuron. It gives the signal when more and more epinephrine is left in this space. Some of it goes and binds to here, some of it is more in this space. So the leftover norepinephrine will bind to this receptor alpha 2 and will give the signals up that please don't make me more. I don't want to be released now. I'm enough already. Don't make me more. So this is inhibitory receptor. It will inhibit this whole process. Okay. So this is also like same as acetylcholine mechanism, but the steps are more. There are more drugs. Like you will be studying the blocking pathways. Now this pathway is a rate limiting pathway. When this pathway is blocked, the tyrosine cannot be converted to dopa and norepinephrine will not be formed. So this is a rate limiting step. Okay. Then there are some drugs that act here, like at this particular level there is a drug that is called reserpine. Okay, if that drug inhibits this uptake of dopamine into the synaptic vesicle. Okay, then we have some drugs that inhibit this this reuptake. Okay, this reuptake of norepinephrine. So there are these MAO and one more COMT. I don't know if it is written over here. Let me see. Yes, we have this COMT. So in our next lecture, because this is a long process, okay, and we will not be finishing it. It needs like another 20 to 30 minutes to explain you this whole process. So once you will understand this whole process of synthesis, uptake, binding, removal, metabolism, and everything. So if you will understand this, it will be easier for you to understand the drugs, how they work. Okay. So we will continue this lecture in our next class, which will be on Friday or like next will be on Saturday. Okay. So it depends if I can take class tomorrow or not. So I have to do certain things. So people, this is all for today's class for pharmacology, and it's 7:04. So our next lecture will be like by 7:15 or something. It's Maghrib already, so we will meet after prayers. Okay, prayer time. So our next lecture will be on neurophysiology, definitely, and then last will be anatomy. So please study. Okay, you have very little time for your exams now. That's all for today. So I'm kind of, if you have any questions, you can ask. We have a little time.